Hey everybody, let me know if you can hear and see me. Welcome to Tuesday. Hey Nicole. And Paige. And Kaylee. Alright. Loud and clear is my favorite way to be. Sandra and Jackson, hello all. Glad y'all could be here. Shelby, how's it going? We'll start here in just a couple minutes. Hey Aaron. Hey Allison. Hey Abby. Liking all the exclamation points. You're very excited. Glad to be here. Ooh, it was not too bad until my my 3-year-old started to get sick. We actually had to pull her out of school today, so that'll be my disclaimer for today. If you hear any screaming, general cacophony, kerfuffles, snafus, that is what's going on. Hey, Cassette. Isabel. Yes, Phoebe. She has been a bit of a wild child today, so I know it's quite sad. Just FYI before we get started. Oh, let's see. Tiffany's asking, is there a formula for giving someone a fluid bolus? Of course there is. We've gone over it before. I'll hit that up on when we get started here, just so everyone has the benefit in case the stream goes down or something. I don't think I do understand how obsessed with her name you are, but I'm glad you are. Glad you approve. I'd hate to have to change it now after getting her used to it for 3 years. That would be unfortunate. Hey, Kelly. Let's see. The 25 is pretty good. Can't find a formula for fluid maintenance, just not the bolus. I will tell you the bolus calculation. It's in your PEDS notes. I can tell you that for sure. But yeah, let's go ahead and get going here. Hey, Kate. And Alyssa. It's just about time, so start recording here. Okay, so yeah, so I graded all of your prescription assignments, so that's all good to go. So you got your feedback for the next one. So a couple things I wanted to touch on in terms of feedback for that. So, oh, actually, FYI, I did re-upload the vaccination PowerPoint. I added 2 slides at the bottom if you want to be super up to date. So if you want to re-download that, you can always. Anyway, so in terms of like fluids, I saw some people were, and again, don't think I'm singling anyone out because a lot of people did similar things. A lot of people would put like a certain volume of fluid to give over 24 hours. So I saw a lot of like 2100 mLs over 24 hours. That's not generally how those orders are written. Typically what you're going to see is it'll just be listed as mLs per hour. So you can take that 2100, that might be an appropriate amount, but then divide it by 24, and that should be your mLs per hour, and that should be how much the patient should be getting. That's kind of the standard for how those orders are put in. I saw some people doing it based off of the sodium content. So they're looking at like what a normal sodium amount would be for their daily recommended intake. We also don't base it off of that. So really, in terms of maintenance fluids, you could either do it to where you figure out how many liters per day they need, or you could just do the 4-2-1 rule, and that should get you pretty close to the same volume there. So remember the 4-2-1 rule: 4 mLs per kilo for the first 10 kilos, 2 mLs per kilo for the second 10, and then 1 ml per kilo for every subsequent kilogram. So for this particular patient who happened to be 50 kilograms, it'd be 40, 60, and then 70, 80, 90. So 90 mLs per hour would be fine. I saw a lot of people get like 88.5 or something, or 87 point something. Those are all within, reason. So I didn't count off if the rates were around that. The other thing to consider too is like what kind of fluid you want to put the patient on. Like, are we putting this patient on to prevent dehydration, or are we doing it for another reason as well? And certainly, yeah, we're doing it to account for insensible losses that occur, while the patient's NPO. But also remember, the patient can't eat for the most part until they can advance their diet. So from that standpoint, having dextrose in their fluids is really important, especially for kids. There's an older kid, so maybe a little bit less important, but still, that's generally speaking. You'll do something like NSD5. If you want to put in some potassium, that's totally fine. So that's what I would say about that from the fluid order standpoint. Some people I did count off because you would have 2 pain order medications, one oral, one IV, but then both of them just had PRN pain. So one of the big things you'll see, especially with the Joint Commission, if you're not familiar with them and how sort of nerve-wracking their visits can be, they try to make sure there's a lot of safe practices in place. And anytime that someone who is not an independent prescriber, i.e. you, or a nurse practitioner or a physician, anytime they're having to interpret orders and making decisions, making their own decisions on how to treat something, that's independent practice, and that's not allowed. So if you have 2 pain medications and they both just say PRN pain, that then requires the nurse to make a decision on which one to give, and that is frowned upon by the Joint Commission because that's outside of their scope. Are there lots of nurses who could obviously tell what type of pain medication the person needs? Absolutely, but that is still not within their scope of practice. So that's why you need to specify, okay, for mild pain, you'll give this medication. For moderate to severe pain, you do it for this, right? So that's kind of what we're going for there. You want to be specific in saying when to use these medications. Just saying something PRN and just assuming it's obvious can get you into trouble, because you know what happens when you make assumptions. You make medical errors potentially, and so you don't want to set anyone up for those issues. In terms of antibiotics, I saw a lot of people switching out the antibiotics. Patient already got a dose of Ancef, so if they got that before surgery and then they're post-op, they didn't have any problems with it. There's no reason to change it, right? You can keep going with the same medication. And I wanted to make a point with that particular med order in terms of when to start medications, because this is a call when I'm working and I'm dealing with post-op orders for patients coming out of surgery. I have to probably call on this 5 or 6 times a day. Right. And so I have to say, hey, you wrote this medication order to start. Patient got the dose at this time. Are you sure you didn't really want it for later on when it would be 8 hours apart? And they'll say, oh, yeah, that's what I meant. But like, I'm not just allowed to go change medication times. I can't just assume that's what you meant. I have to go and call you up. And so, of course, that slows down the whole process. It keeps you from seeing more patients, keeps me from doing my job. So in order to be specific, you can say, hey, start this at this time. Right. And so those are always like the rock star PAs that I see whenever they can be really specific about their orders and say, hey, this medication to start at this time, and then they'll go from there. And again, for that 24 hours of coverage, all you really needed to do, because since they got a dose at 8 o'clock, is just do, you could just write, Ancef 1.5 grams IV, Q8 hours times 2 doses to start at 1600. That's as straightforward as you can possibly make that. And again, this is the time to make mistakes because you're new at it, so you'll get more experience with that as you go along. That'll make more sense, I believe. Other than that, were there any other questions regarding the prescription assignment and anyone's feedback? If you have anything specific you want to send me, feel free. Otherwise, if you have other questions. So to go back to Tiffany's question for fluid bolus, those are always 20 mLs per kilo. Again, for adults, cap it out to be between 1 and 2 liters. If they have something like, they have renal failure or they're edematous, then you can go halvesies and just say 10 mLs per kilo. You can always give more fluid. Again, it's hard to take it back, right? Unless you're going to diurese them or dialyze them or something like that. So, okay. But if you have questions, let me know and I can try to address those. Someone has said, what do you think about the news with Johnson & Johnson vaccine? Good question. I'm going to get to it later. That's what I updated in your slides. I knew the second my wife said, "Did you hear about the vaccine?" And the first thought I had was, "Oh, great! Now I got to update my slides." So luckily, I was able to get that done before the class started. So that's all updated. So I will get back to that. No problem, Tiffany. Sometimes why is a combo of an NRTI and two NRTIs less preferred compared to the example PI and two NRTIs? Is this because of similar mechanisms? No, they work together fine, but remember there's in terms of tolerability, the integrase inhibitors are kind of taking the stage as sort of the recommended first line for a majority of patients. And if you look at the hivinfo.nih.gov, you'll see they kind of recommend that as like, this is our first line, but here's some others you can use as well if you found a compelling reason to do so. With the NRTI or NRTIs, they tend to be kind of rougher on the liver than something like an integrase inhibitor would be. Protease inhibitors have a lot of those metabolic effects you can see over the long term. And also the NRTIs, remember that once you become resistant to one of those, you basically lose the majority of the class. I think except for retrovirine was the exception there. So if you can hold off on using those, that's generally going to be preferred. You can save those for down the road in case you really need to use it. But just from tolerability and resistance, it's probably better off to go with like an integrase inhibitor, maybe a protease inhibitor, just depending on sort of the situation there. So. And then they also asked, is it also true that Tecnivi and Vicura are discontinued? So I brought that up. Here is the page for, this is Tecnivi. And if you can see here, if you look at if you're like looking at Lexicomp, or if you look up a drug through Up to Date or something like that, if you go to jump to section and then go to dosage forms, this can be handy to see like what specifically is available. So if you didn't know like what a tablet size was for something, or what concentration like an oral liquid comes in or something, you can always look here, and that's really good info. So you can see here that it's still available. If it's discontinued, which it looks like this was the case in Canada, is that they discontinued it. But as far as I can tell, at least from this, and this is usually pretty up to date, that this is still available. And that was the same thing for the Vicura. Bring that up as well. You can see here dosage forms, the 28-day supply is still available. In Canada, looks like it's available there too. So if you see something conflicting with that, feel free to let me know. Okay, so there's that. Let's get into our PowerPoint. Any questions before I get started here? Gotta stay hydrated, very important. Okay, so getting into our immunization. So this is something, you may have a tough time with, especially depending on your patient population you're dealing with, especially if you work in pediatrics. This can be a bit of a challenge here, but just a brief bit of history, just to kind of, if anything, give you some appreciation for kind of how we've developed vaccines since the beginning. I mean, back in the 1600s is when we really kind of figured out that, hey, we can do like an inoculation with smallpox. We can transfer some pus from an infected person to a non-infected person, and then, hey, now you don't have smallpox. You do have someone else's pus inside of you, but hey, no smallpox. I guess that's a good trade-off. But since then, we realized as well that, you can get cross-reactivity here. For instance, people who had contact with cowpox, like milkmaids, didn't get smallpox, right? So they're starting to kind of figure out, okay, yeah, maybe there's something to this whole, immune system thing here. Interestingly enough, vaxa is Latin for cow, so every vaccine you get is at least somewhat related to cows, which is kind of interesting from that standpoint. And then from there, Pasteur developed things like the rabies vaccine. We have things like polio vaccines. It's interesting because we also see there's different dosage forms you can use. So for instance, an oral polio vaccine introduced back in the 60s. Again, I'm not going to quiz you on the specifics of the history. This is just to kind of give you sort of a brief overview. And here's an example of just all the preventable diseases, that we have vaccines against, which is pretty, pretty diverse, which is fantastic. You can see here that, not all of these are going to require, right? And we'll see that as well, that, in certain cases we may recommend these, for instance, certain travel. So, for instance, if you're going to be going to South America, or if you're going to be going to Asia, they may have different recommendations, assuming we ever get to travel again, which may be on the horizon, who knows. some of these are associated with preventing certain types of cancer. I mean, there's all kinds of things we can do here. And so basically what I'll do is kind of take you through sort of the basics of like how these vaccines are working, the different types that we have available, some of the caveats with how we're going to use them. And then I'll get into specifics in terms of, kind of highlight certain ones that I think are interesting or sort of unique, and then kind of go through that. And then we'll kind of finish out by talking about the COVID vaccines, because they do introduce a whole new type of vaccine that we've never had available before, which is pretty cool. And then we'll kind of see some of the upsides, the downsides, talk about things like when they say this drug is 95% effective, what does that really mean versus 65% effective? We can look at some of the specifics there, which I think is really interesting and something that's going to be pertinent to, you talking to future patients, you talking to your family members, maybe over holidays, things like that. Here's just an example of the reported incidence of polio. You can see here the different lines here. The blue line is kind of what we said, the actual percentage coverage people immunize versus the WHO, what their estimated amount was. But you can just see the number of cases just kind of plummet as vaccination rates started to increase, which was really fantastic, right? Because no one likes polio. And so there's a lot of reasons why people don't want to receive vaccines, right? And so it's important not to just like look at someone who is, who is hesitant about vaccines to just say like, oh, well, that's stupid, just get it, right? Because, I mean, they may have some valid concerns. And so, it's always important to go into conversations with an open mind. It's much easier to be curious and kind of like guide someone towards the right answer or the decision you think is right for that patient, rather than just tell them, no, that's dumb, this is the way you should do it, right? Because that closes off a lot of people pretty quickly. And honestly, you see that a lot like in certain types of practices, so like, for instance, I see a lot of ER people who tend to get kind of jaded to some of the stuff, and they say, well, that's dumb, why didn't you vaccinate them? Your kid or something like that, and that's really, I think, the kind of wrong approach to take. It's not everyone, but you'll see that occasionally. Anyway, so what are some of the concerns here? Well, things like adverse effects, right? No drug is without adverse effects. So they may be concerned with things like Guillain-Barré. They may be worried about things like anaphylaxis, things like that. Maybe they have insufficient time, or if it's an inconvenience to go get it, right? Maybe they're working 2 jobs and they're unable to find time where they can actually go and get it done. Maybe they prefer alternative types of medications to keep themselves healthy, things like homeopathic meds. Some people want to avoid all medications as it happens. I've had students before who have basically told me right at the beginning of the class to say, like, I don't really believe in medications. I said, okay, well, that's certainly a stance to take, but you're still going to have a lot of people taking medications. You still got to know something about them. You still need to know what they're doing, because again, they do have effects here. Some people are deathly afraid of needles, and I see this big time, especially I think just recently there were some news stories about people practicing, or not practicing, but they were celebrating spring break at Miami Beach, and they say, I'm young, I'm healthy, there's no way I'm going to get sick, or if I do get sick, I'm going to be just fine. Or if like everyone else gets one, then I don't need one, right? So there's sort of a low personal, or a perception of low personal risk that may make them less likely to go and get it themselves, right? I'm young, I'm invincible, all that good stuff, right? Someone says, why do you think even healthcare professionals with more than adequate educational backgrounds, there's so many anti-vaxxers? That's really a tough time. And I'll tell you, and of course I won't name any names, but I've seen cases to where, hospitals will have mandated flu vaccines. They say, okay, you have to get your flu vaccine every single year. Otherwise, if you don't, then during flu season, you have to wear a mask. And I've seen cases of like nurses who would sort of, and I'm sure this happened with other professions as well, but I particularly saw this with nursing just because, they're sort of the most voluminous in terms of healthcare healthcare practitioners that are around for the most part. And they would sort of say, hey, I'll go ahead and sign you off. Say you got the vaccine. Here's your sticker. You can put it on your badge and don't worry about it. Right. And I'm like, that's pretty messed up because, that's putting yourself at risk. That could be putting your patients at risk, especially if you work in places like HEMONC, if you're working in different areas where you have particularly susceptible individuals. So, again, it's really kind of interesting, too, just some of the even though you consider medical professionals to be educated, they may have varying beliefs. There's a lot of things that you can see out there that people will believe. out there. So, it's just like, you can have, pharmacists who take moral stances and say, I'm not going to give out birth control. I'm not going to do plan B, even though, it could be really within the patient's best interest to do so. So I think I don't know, I wish there was an answer for you, but it's pretty wild. So I can't really speak for anyone besides myself, unfortunately. But I do agree that's pretty messed up. But just wear a mask. Just wear a mask instead. That's they gave you an out. If you have religious concerns or if you have moral objections to vaccines, you can do something different. But to lie and then try to subvert the system, I think that's where it seems kind of more like negligence than anything else. But anyway, beyond that, right, so just to give you some ideas of things of past programs that have been successful, and then kind of what happens when you see things start to dip, because people think, okay, a disease is gone, it doesn't happen very often, things get a little bit lax, right? You think there's a low personal risk to yourself. So for example, back in Japan in the 70s here, they had this really successful pertussis vaccination campaign. So about 80% of those Japanese children were vaccinated, and they had relatively few numbers of cases there and no deaths related to the disease in the country. So pretty good, right? So then there's kind of some rumors spreading around that said, well, this pertussis thing is sort of, we kind of nipped it in the bud, so it's no longer needed, and that maybe the vaccine wasn't safe, right? So then at that point, by 76, so even a 2-year difference, only 10% of infants were getting vaccinated, and then what do you know, 3 years later, there ended up being a major pertussis epidemic, right? So then you see 13,000 cases of pertussis, 41 deaths related to it. And again, you always want to say, okay, well, is it correlation or causation? But I think, when you look at numbers like that, it's kind of hard to not see sort of a trend there. So then at that point, by 81, the government started vaccinating with the 8 cellular pertussis vaccine, and then they started to see the cases drop. Right, so it's sort of the classic thing where if you remove the influence and then you see the cases go up and then you give the influence back again, so in this case the vaccine, cases drop, pretty clear sort of cause and effect there can then be demonstrated, right? And we see a lot of people die every year from vaccine preventable diseases for sure. And for instance, 3 of every 1,000 people with measles will die, which doesn't sound like a lot. So yeah, your personal risk is fairly low. But you're going to see that, if it happens to your kid, for instance, then that risk is 100% at that point, right? So something to kind of consider there. Just some other kind of facts and figures you can see with that. So for instance, things like, measles, mumps, and rubella, how that can prevent a lot of things like, heart defects and whatnot, things like the varicella vaccine. So again, and I'm sure for most of you, I don't need to tell you that, yeah, vaccines work, right? It seems pretty obvious, but for other people, it may not be that way. And so you may need to give them like actual clear-cut examples of sort of what's happened. Like, we introduced this vaccine, this is what happened to the numbers, and sometimes that can help them to sort of guide them to your side of the argument there. So let's talk about different types of immunity that you can run into. And again, hopefully I'm not offending anyone. If you have different viewpoints, I'm certainly happy to talk about them if you want. I'm just kind of speaking from my perspective of that I believe vaccines do work. And I think you guys most of you probably do. But, if you have dissenting views or if I offend you or anything, let me know. We can have a conversation about it. I don't want anyone to feel, sort of singled out or anything because their views just don't line up with mine. That happens all the time. Anyway, so with passive immunity, this is basically where we're getting protection transferred from another person or maybe an animal potentially as an antibody. Benefits of passive immunity, and this is probably a review for a lot of you guys, but just to sort of get us all on the same page. Benefits here are that you get immediate protection, right? However, you're going to see that the duration of action for a lot of these tends to be relatively short, so only weeks to months in some cases. So some examples of how this could occur could be things like immune sera. So if you have things being transferred through the placenta or perhaps through the breast milk, that is passive antibodies being given over from the mom to the fetus or the infant, and then that can protect them for a period of time. And that's actually going to be influencing when we actually vaccinate some of these kids, which I'll show you some examples of here in just a little bit. Again, I'm not going to have you memorize like the whole pediatric vaccine schedule. I'm going to show you the scheduling. I'm trying to show where you can find it so that way you can at least look some of that stuff up. But actually the timing of some of those vaccines does matter based off of things like, okay, well, do they have passive immunity from the mom, and could that affect are vaccines that we're giving the patient down the road. So I'll kind of touch on that in just a little bit. We can have things like pooled immunoglobulin that we can give to patients. So for instance, if we have people who are immune to hepatitis A or hepatitis B, we could then pool that serum from donations. And then if someone has a really horrible case of hepatitis A or B, we could then provide that immune globulin to help neutralize that. So that way they can kind of fight off that infection themselves with the additional immune globulin. Obviously, that's coming from human sources, so you may have some people who are hesitant or may have objections to using that, but that's one example. And then even things like antitoxins can be useful here. So this is where I get into these most frequently in terms of things like snake antivenom, which we'll talk about a little bit when we get into the tox section later on. But basically, we can hyperimmunize animals to things like snake venom, to that's kind of the main ones we use them for. But things like digoxin potentially, and that way we can have antibodies that we can extract from them and then use it to neutralize that in the patient. So we talked about like Digifab before, Digibind for digoxin. That is derived from sheep immune globulin that they have hypersensitized against digoxin. Or for instance, we used to use a lot of more horse-based immune globulin, but unfortunately that happened to be very immunogenic, caused a lot of anaphylaxis. So nowadays we use a lot more ovine sources, so sheep sources basically. Someone had a question here. Someone said, "Thank you for explaining all this material so well. You really give us a non-biased approach and so appreciated." I mean, I try to check my biases a little bit, but things are gonna sneak through here, but I'm glad you appreciate that, so you are very welcome. I'm sure there's probably some other people who are like, screw that guy. That's okay too. I understand that. That would probably show up in my evals. Yeah, one or two like that, but that's all right. Anyway, so that's where I see a lot of antitoxins. We'll talk about different venomous snakes in Florida, and if you're new to Florida, we have a whole lot of venomous snakes here. So like I said, we're kind of the Australia of US, I would say. I would contend for that, I think. Anyway, whereas we have passive immunity, here's active immunity, where basically we are producing our own antibodies against that, right? So we do have to have an initial exposure, but then we can generate our own antibodies, and we typically see that you'll have a little bit of delayed protection. Yes, we have a lot of danger noodles here, so don't boop their snoots because they can be quite dangerous. But basically, you're going to see this delayed protection, but you get very good durable responses here, right? It could be lifelong in some cases. Again, I apologize for the kerfuffle heard outside of my room here. I think my 4-year-old just got back, and so they're a little cranky. Anyway, so durability can be variable depending on the agent that you're getting there, but could be lifelong in some cases. So this is either due to natural disease or from the vaccines themselves that we can give in some cases. Someone says, "What do you mean when you say we hypersensitize animals?" That basically means, I'm glad you asked because I like talking about that kind of stuff. But so imagine if you were to give, take a horse for instance, any horse, and you gave them tiny amounts of snake venom, and then you gradually built up their resistance to it because they can develop antibodies against that. We could then take those antibodies, spin them out of the blood, isolate them, and then give that to people, basically, and they can neutralize something like an venom. We can do the same thing for digoxin, as I mentioned. There's a few other examples. So there's like a tetanus toxoid you can use. There are different options that are there potentially. So that is what I mean by that. Let's see here. So what are some things that help us determine sort of like how well someone's going to respond? It is pretty wild. I agree, Aaron. What's going to help us to determine, actually, it's even more wild to people that tried to immunize themselves against snake venom. There's a guy who apparently thought that he could immunize himself against black mamba. And apparently I guess he might have died at some point, but I'm not sure if it was from a snake bite or something else. But yeah, it's pretty interesting. I would not recommend that. Anyway, so what are some reasons why people may have good responses to a vaccine versus not? Well, some of it could be related to the actual viability of the antigen. We're going to get into things like live attenuated versus inactivated vaccines. If you give something that's able to replicate on its own, but maybe it's been weakened so it can't cause disease in the person, you may get a better response than if it's just like a chunk of the virus or the bacteria, or if it's like more of like an inactive sort of portion of it. Things like the dose of the antigen matter. So like how often are you getting it? Just a one-time deal, or is it something you're going to get 2 or 3 times potentially? And then even the type of vaccine. We'll talk about things like polysaccharide versus protein polysaccharide, and you may see of how big of a molecule it is. The patient's immune system might have a better chance of kind of latching onto it, so to speak, and being able to develop those antibodies. So we'll talk about some instances of that with infants. I'm talking about the pneumococcal vaccine. And then sometimes even the site of administration can make a difference too. Like if you're giving it in the deltoid versus the gluteal area, this is kind of less commonly going to be an issue there. Other big determinants that have to do with the host is the age of the patient. How competent of an immune system do they actually have, right? So if they're very, very young, then you might not have a very competent immune system to fight off that organism, to develop the antibodies. You could have presence of maternal antibodies, which sort of neutralize the disease before the body has a chance to even react to it, right? Look up snakes and hats, you won't be disappointed. I'm sure I won't. Hopefully they're not my hats. But yeah, so you can have the maternal antibodies actually neutralizing and preventing the patient from having the ability to develop their own immunity. So that's why you'll see some infant vaccines delayed until about 12 months or so, because by then the patient is able to sort of mount their own response. Usually maternal antibody concentrations have dropped by then. And so that can be one way we can get better effect out of that, by delaying when we give it. Intervals between immunizations, we'll talk a lot about when to receive vaccines, and then we'll see also coexisting disease, right? So if your body's already sort of ramped up and fighting off a different infection, could that have an effect on your ability to mount a response to this new sort of this new challenger, so to speak, right? So that can also be playing a role here as well. The main types we're going to get into, and I'll talk about some of the newest ones when we get towards the end here, but we have live attenuated, which is basically, it's a live virus or bacteria. It's just been sort of weakened. It's sort of the wimpier version of it. And so you get a very similar response to the illness, but you shouldn't really see the patient get as sick as it would be if it was sort of the natural wild type disease, right? So that's one way to do it. We'll see there's a killed or inactivated, so we actually can kill off the microorganism, so it's the whole thing, it's just dead. Or we can maybe give like a portion of it potentially, as we'll see here with the fractional. These you're going to find may not be able to give you as big of a response, and so this is where you see a lot of like repeated doses being needed in order to actually develop the immunity. With the fractional ones, you can see you can base it off of certain portions of the organism. So whether it's a protein, right? So you can have like a toxoid, which the body can try to latch on to, or the subunit, for instance, or it could be based off of a polysaccharide, a sugar that the organism can express that we can then have a response to. So like when we get into the COVID vaccines, we're going to see that the main thing we're going to be looking at is a spike protein that is going to be our target for our immune system to try to fight against, right? To develop antibodies against. So look at some options there. There's some that are recombinant, which we can actually sort of engineer I'm sorry, my kids are going absolutely wild out there. But there's recombinant forms we can make. We'll talk about a few flu vaccines that are like that. And then, as I mentioned, the Immunosera, which is basically just pooled, donated human IgG that gives them sort of that passive immunity there. So thank you for providing the snake with a hat. Oh, I'm going to leave. Yes, those are screams you hear. So if you ever need a reason to not have children, that might be one. I don't know. I'm just kidding. I love my children. I'm going to leave that snake there all the rest of the lecture for you, just in case you need a little bit of a boost to get through that. Okay, so going back to other components. So this is, can be an issue. That was a car screeching outside. Yeah, it was someone doing some sick donuts. It was not my 4-year-old having a meltdown for sure. Anyway, so some other things that you can find in the vaccines, right? So it's not just like you get the initial component that your body is reacting to. There's all kinds of other stuff that's in there too. And this is what some people will have some hesitancy with in terms of being like vaccine phobic or being anti-vax, is they worry about what all the other active or inert ingredients might actually be, right? And this could be the source for some of the allergies that we can see with this as well, right? Or if you have a bad reaction, it could be related to some of this. So for instance, things will have, some of these products may have water, saline, albumin could be used potentially as a vehicle, not like that car out there doing donuts, but it could be like something that the agent can sort of bind to be carried into the body. You'll see things like preservatives or stabilizers or antibiotics that help to keep the product sterile and or stable. So for instance, like thimerosal, which is a mercury-based preservative that has, I'm sure some of you have heard, heard about that as potentially being linked to autism, for instance, because mercury itself can be a neurotoxin, right? But we'll talk about that in just a little bit. And again, that could be a source for allergic reactions, right? So for instance, with a lot of flu vaccines, they do contain egg protein. And if you have an allergy to eggs, then that could be something that could be a contraindication for you, as an example, right? And then different manufacturers may have different inactive ingredients, right? So again, that could be something you may need to look into. And it's like, well, where do you even find what the inactive ingredients are? And that's where you can go to the package inserts. Every drug has a package insert. You can look into that and see what specifically is in there. See if your patient has, a history of reaction to a certain type of preservative, for instance. And if you can find one without that, then that may be good for them, right? So the live vaccines, as I mentioned, they're going to be attenuated or weakened, right? Kind of two words for the same thing. The wild virus of the bacteria, and they're replicating in order to be effective. So just like they would normally, they'll replicate. They just are not able to cause as severe of a disease. And the immune response should be pretty similar to the natural infection you would get otherwise. You also see a very good durable response, right? And when I say durable response, what I'm talking about is sort of that memory. How long does your body keep that immunity for? Good durability or good memory, immune memory, means you need fewer doses, sometimes just one, right? Because they are alive, they typically are less stable, and then potentially they could be interfering with other circulating antibodies. So for instance, if you have maternal antibodies, I think IgM, I believe, circulating around, they may be able to neutralize that attenuated virus or bacteria, which may not make it possible for you to develop your own reaction if you were an infant there, right? You also have some severe reactions, and you want to be careful using these in either immunocompromised patients, those that are pregnant, and or infants, okay? Those patients are ones that are more likely to develop the actual disease itself. So it's like kind of a whoopsie where like, okay, I gave you this weakened version, but you have such a weak immune system, they're not able to even mount a response to that, and they could actually get the disease in question. So when we talk about contraindications, that'll be an important one to live vaccines specifically, okay? So kind of keep that in the back of your mind. Some examples include our measles, mumps, and rubella, varicella zoster, the intranasal influenza, rotavirus, BCG for tuberculosis, and then oral typhoid. So just to give you some examples, I'm not going to ask you on the test, is this one recombinant or not? If I get into specifics, I'll talk about that as we get into it a little bit later on. But these are just some examples for you. With the killed or inactive, as I mentioned, they don't replicate or cause disease in the recipient, so they're less likely to cause any problems for those with immunocompromisation, right? Or if you're an infant. You'll see here that, again, you'll have more minimal interference with circulating antibodies. It's not likely to trigger those around, so that's why you can give these to infants. It's generally okay. It shouldn't react with the mother's circulating antibodies. You typically need larger doses. You also will see that the immunity is also more temporary. So you generally need to kind of re-challenge the immune system several times before you really start to see good passive protective responses. So like maybe 3 to 5 doses in some cases. However, you will start to see some protection after, say, the second or third dose. Right, so it may not be full, just like, for instance, like we have some questions about the COVID vaccine now. It's like, okay, well, am I protected at all after the first dose, or how long before after the second dose? So with these, you typically get some response after the second or third dose there. And as I mentioned, you may have antibody titers that will dip down over time, which is why you may sometimes need booster doses. So I talk about like hepatitis B. I got a booster dose when I started at Nemours, and so that because my titers were getting low. So I said, okay, let's give you a little tune up here. And again, that helps to retain that immunologic memory, right? It helps with the durability of that response by kind of re-challenging it and kind of getting more circulating antibodies available, or getting those B cells up to par. Here you can see ones that are either the whole organism, or it could be basically a fraction or a portion of it. So for instance, with like influenza, we see it's a killed or inactivated form. So the injectable form is a killed or inactivated type. With bacterial, you can see there's many types, pertussis, typhoid. With the toxoid, sometimes it's not even the organism itself, but actually the thing that causes the problem. The actual toxoid that it's releasing is what we can actually mount a response against in some cases, which is interesting. So next we then have our polysaccharide and conjugate polysaccharide. These are basically sugars that are found on the capsule of a bacteria and allows our T cells to sort of develop antigen or T cell independent antigens there. So we're still able to mount a response to that. However, you're going to find that really young patients have a hard time sort of latching on to that, just that polysaccharide. And so in some cases, what we can do is actually add on a protein to it, kind of make it a little bit beefier in size. And then that allows for a better immunogenicity. So for instance, kids as young as 2 months of age, they can get the pneumococcal, that's the protein polysaccharide conjugate vaccine, versus older patients, they can get just the pure polysaccharide. So kind of some differences there you might see, which is why you may be like, well, why do I give this one for kids, but this one for adults? Some of it has to do with the type of vaccine and just how immunogenic it happens to be there. So there's also some recombinant ones. So this is where basically we can insert viral gene segments into something like a yeast or maybe like an E. coli potentially, and then the yeast cell or whatever happens to be, it just produces pure antigen that your body can then mount a response against. So for example, hepatitis B is a type of recombinant, the HPV vaccine or Gardasil is a recombinant form. And then you can even have live attenuated recombinant vaccines, although this is not quite as common, but probably the most common one you run into is the intranasal influenza. So basically it's a weakened form that we have sort of engineered basically, which is kind of interesting. So we made a yeast cell produce this virus that is a weakened form that you can then get a response against. When I was doing some reading, I actually was finding is like, well, like what's the difference between an intranasal versus an IM sort of vaccine? And it's kind of interesting because with a lot of respiratory diseases, the thought is like, well, where are you getting those virus particles from? Well, it's usually in your respiratory tract, either in your mouth or your nose. You're going to be inhaling this stuff from the environment. So it's like, well, if you give something locally, they actually find you get better antibody titers there locally, but you get less systemic response. And vice versa, if I give something in the arm, I'm going to get really good systemic antibody response. But if you were to actually look at the actual respiratory tract tissues, it's a little bit less. Clinically, we don't know if there's really that big of a trade-off there, but it's kind of interesting they've looked into that to see like, okay, why would we give something intranasal? And that's potentially one of the reasons why there. So how we time and space out these vaccines, as a general rule, all vaccines can be given at the same visit as all other vaccines. So whether it's getting live attenuated versus an inactivated form, if they're all due at the same day, you can give them all together, no problem, okay? When you start to giving them separately, that's where some of the timing is going to be important here. So if it's 2 or more inactive vaccines, you can either give them at the same time or at any interval. They're not really going to interact with one another, okay? If you're giving an inactive and a live vaccine, you can either do it together or any interval, no problem. The only exception is if you're doing 2 or more live, you either want to do them simultaneously or you separate them out by 4 weeks, okay? You find that if you like give one live vaccine today and then another live in 2 weeks, they tend to sort of compete with one another in terms of what your immune system is trying to mount a response against, and you may not get as good of a response out of the second one potentially. Again, if you do it simultaneously, it tends to not be a problem. Okay, so for whatever reason, 2 or more live, you have to separate them out by 4 weeks. Okay. When you have vaccines that have to be given as multi-dose series, which we'll see that especially on the pediatric schedule there, the minimum time between doses is generally going to be 4 weeks. So you may see that as the minimum there. And then typically between the next to last and the last vaccine, you give probably 5 or 6 months or so. So that's why you'll see that, especially I think with the MMRs, where you see that kind of that gap there. And so by giving that, it allows the body time to sort of kind of rest and recover, and then you hit it one last time, and you really solidify that sort of immunity with that very last dose there. So minimum of 4 weeks, and usually if you have like a 3-dose series or a 4-dose series, you give a longer period of time between the second to last one there. Okay. Increasing the interval does not really appear to diminish the efficacy, but it may delay the response and it may delay how fast patients develop protection. But decreasing the interval actually can interfere with that antibody response. You may get less protection overall. So if you can space it out a little bit more, that's better than giving it too soon in a lot of cases there. Okay. Generally speaking, delays with the immunization does not necessitate restarting the series or adding additional doses. Within reason. If it was like 6 years between their last dose and the next one they probably need to restart the series. If it was an extra month or two, probably not going to be a big deal, right? Someone had a question here. Some said regarding the Hep B vaccine, should everyone have their titers checked regularly to determine if their immunity has decreased so they can get a booster shot, or is it only indicated for people who are at risk for getting Hep B? My understanding is it's generally for people who are at risk, which healthcare providers, in case we get like accidental needle sticks or something, could be one of those at-risk populations. I mean, like my risk is fairly low since my direct patient contact is a lot less than say like, a PA or a nurse or someone. However, it was still just hospital policy. So I don't know if there's any recommendations specifically to those that are relatively low risk to have to get checked necessarily. But that is, if there was recommendations about that specifically, I may be ignorant of them, but you can look at the CDC and they can give you better guidance there. That stuff's usually up to date there. A lot of this like vaccine stuff I generally have to like look up because I just do it every once in a while. So this is why I'm always err on the side of let me look it up. So we had technology for pics on the sticky. That's probably a bad idea to let you guys know that. Perhaps we should not let that secret out of the box. So I might get some inappropriate pictures put out there. So let's not do that. How about that? Anyway, so you're going to see with patients who are immunocompromised, it may reduce the overall efficacy of a vaccine. And again, if it's a live vaccine, it may actually pose a risk for having that disseminated disease. So in general, if they are getting something that is immunocompromising, so like radiation, chemotherapy, if they're going to be like on a disease-modifying drug for rheumatoid arthritis, if you can vaccinate 2 weeks before or 3 months after they have been exposed to whatever the therapy is, that will provide good vaccine response. If you do it during, then you may not see a very good response to that, and you put them at risk for developing the disseminated infection. For the live vaccines, I'm sorry, and in general for the attenuated, or not live attenuated, but more of like the killed or inactivated form, you can still give them while the patient is immunocompromised. And I wouldn't say like not to give them if it's something like their yearly flu vaccine, they're receiving chemotherapy. They might not get as good of a response, but it still would be better to have some response than none at all. So if it's a killed, attenuated, or killed or inactivated form, that's okay to do if they're immunocompromised. Just know they may not get as good of a response. But the live attenuated forms I would not give while they're immunocompromised. Either do it before or do it after. So someone said, sorry if you said the vaccine interval ends up being more than 6 months and it's better to restart the series. I said 6 years in that example there. Again, if it's something to where the normal time frame was like 5 to 6 months between the second to last and last dose, and come in and it was 9 months later, I probably wouldn't restart the series. I'll just give them that last dose and they're probably good to go, right? But again, it's within reason. It's been 2 years, 3 years, yeah, that's probably too long. I'll probably restart it at that point. But again, everyone might have a little bit of a variable opinion on that. There's not quite as good evidence or guidance for that in particular, unfortunately. So, and then looking at separating live vaccines and antibodies, right? Because antibodies can interfere with your vaccines. It could basically just neutralize them immediately and prevent the patient from developing a response in themselves. So if the live vaccine is given first, and you want to wait at least 2 weeks before giving the antibody. Okay, so that way it doesn't mess up your vaccine. If given less than 2 weeks, then you can try to test for immunity or repeat the vaccine if need be. And then if the antibody is given first, then you may actually in some cases want to wait 3 months or longer for the vaccine. There are some exceptions to that, so we're going to look at some examples, for instance, with like rabies, where that's like a very life-threatening condition if it occurs. And so we'll look at some of the specifics of that with the immune globulin and the vaccine scheduling and all of that. So here is a slide that kind of gives you some ideas of whether or not something is a precaution, meaning you should be careful if you're going to do it, a contraindication, meaning don't do it at all, or V means just go ahead and vaccinate that individual there. So if a person has an anaphylactic allergy to a component of the vaccine, contraindicated. Don't give them that kind of vaccine, whether it's live or inactivated, doesn't matter. History of encephalopathy due to a vaccine, those people would also be contraindicated. That'd be pretty rare. Live vaccines for pregnancy, I would not recommend it, although vaccinate if they're inactivated. So like the inactivated flu vaccine is okay for pregnant patients. The recombinant live attenuated form for intranasally is not okay for pregnant patients, okay? Immunocompromised, live vaccine, don't do it, but go ahead and give them inactivated. Again, they may not get the full response, but some response is better than no response. Severe illness, again, is a precaution. Again, some people feel you want to wait for them to get over whatever illness they have, whether it be pneumonia or cold or something like that, before going and vaccinating. So that's sort of a question there. And then in terms of recent blood products, because those blood products may have antibodies themselves in them, again, kind of a precaution, maybe something you want to test for immunity later on if it's a live one. However, if it's inactivated, go ahead and vaccinate, and you're fine from that standpoint as well. Okay, so kind of know when you want to be cautious, when it's okay to vaccinate, when it would be contraindicated, because that's a good area for test questions to ask. For what reason would patients be getting antibodies? So again, if it's a blood product, right? So if I'm giving you, for instance, the Hep A antibodies, right? So that's pooled from human sources. We'd be giving that, and then if you want to vaccinate against Hep A, which again, it's questionable if you give them the antibody, if they're going to be able to develop their own response against that, then you would want to not vaccinate at that point, right? You want to save it probably 3 months before you actually gave them the vaccine series at that point. So there's different situations where you may be giving antibodies to those patients, or like IgG. We'll talk about that a little bit later as well. So we'll get into some specific examples that'll make more sense in just a little bit. So in terms of contraindications and precautions for specific types of vaccines and different components, again, some of these are going to be very specialized. I'm probably not going to ask specific questions off of here. This is something you can, again, ask the patient about what their allergies they have, and then try to compare that what you're going to give them. Again, this last slide I think is fair game. This one here, I'm probably not going to get real specific because I think it's just kind of mean, and you can look the stuff up. Note that latex is a component for a lot of these vaccines, so this is going to be a contraindication. If they do have a severe latex allergy, they're probably not going to be able to get very many vaccines, although it's, again, rare to find that. But then certain antibiotics like neomycin, streptomycin, some bit of aspirin is included with the live attenuated influenza vaccines, part of the formulation. And then eggs is another big one. So especially for flu, we have certain forms that don't have any egg protein, but a lot of them do. And so that's why I always want to ask about egg allergy, specifically with the flu. And again, flu is something that people are going to get every single year, so that's why you want to keep that in the front of your mind. You know, some of these you only get once in your life, maybe, but flu is going to be something you always get. You know. So anyway, so in terms of routes that are available, sub-Q, IM is probably the most common one you're going to get there. Certainly, there's a few oral varieties, and for instance, like rotavirus, which you can give for little kids. And then intranasal, an example, would be a live attenuated influenza, but most are going to be IM. A few might be sub-Q there. Now the garbage truck's going to be by, so we're just going to get noises the whole time, waiting for the landscaping guys to show up. In terms of IM spots, so typically for infants and toddlers, you can use the lateral aspect of the upper thigh is typically a good spot. For most children and adults, go ahead and go with the deltoid. And then you usually avoid the buttocks for issues in terms of getting somewhat inadequate responses in some cases. So that's why we go ahead and avoid that. And again, the deltoid is usually pretty easy for the most part, most people. Unless maybe they don't have deltoids. I don't know, maybe they got lost somewhere. But we're going to see in terms of adverse reactions, what are kind of common things you're going to see with this? Well, you can get some pain, some swelling. I'm sure some of you have already gotten the COVID vaccine. My arm was like super sore after both doses. You're going to see this be a little bit more common with inactivated vaccines in some cases. Generally speaking, mild and self-limited, right? And you can self-medicate with some Tylenol or something like that. That's totally fine. Now, systemically, and again, this is always something I hear from people that say, oh, every time I get the flu vaccine, I always get the flu. Like, well, I think if you really had the flu, you'd be feeling a whole lot more miserable. But it's okay. You're expecting to get some sort of systemic response. Otherwise, you wouldn't really assume the vaccine's doing a whole lot, right? That's the whole point of it, is to lightly stimulate your immune system to get some kind of antibody response. So again, fever, malaise, headache, pretty non-specific symptoms here. And again, they can treat it with antipyretics, analgesics. That's totally fine, right? I think some people have some concerns about giving, anti-inflammatories like NSAIDs. It might reduce your response. I've not seen anything that backs that up necessarily. So from that standpoint, I think you're probably okay. But some Tylenol, relatively safe and easy to use as long as they don't have any contraindications there. And again, allergic reactions, pretty rare, although we will minimize this by screening, making sure we're asking the right questions about allergies, things like that. Egg allergy, especially with influenza, as I mentioned before, is a common one. But it's going to be on a more case-by-case basis depending on which vaccine you're giving there, right? So here's an important resource, and actually this goes back to that J&J announcement. If you're not familiar with it, I'll tell you at the end here. But this is something to where we have the VAERS program, or the Vaccine Adverse Event Reporting System. So this is something done by the FDA that they are monitoring constantly for new adverse effects showing up from vaccines. And this is something to where they will, even if you don't know for sure it's related to the vaccine, you can still call them up and make a report, and they can then do some investigating to see what's going on. And this system will be really important, as we're going to see here in just a little bit, because it came up actually today when we actually started to pull one of the COVID vaccines from use here. Someone says, are there any known interactions between vaccines and steroids? So there probably is to some degree, since the steroids happen to be, anti-inflammatory to a big degree. So I would almost treat steroids if they're on if they're like on a 5-day course or something, probably not going to be a problem. If they're like on relatively decent dose steroids for like a rheumatologic condition, I would kind of consider that to be close to the same boat as if they were immunocompromised, due to being like on a DMARD or something, right? They're probably going to be on other anti-inflammatory drugs anyway, so that could certainly be a concern. I would definitely want to talk to like the rheumatologist or whoever's prescribing that to see if they have any specific recommendations, because again, they know these patients a lot better as well, and again, depending on the dose of the steroid and some other factors, it may make a difference or not. It's a good question though. But yeah, I could certainly see some issues there. Someone's saying, can you pre-medicate with Tylenol or something else before receiving the vaccine to limit systemic effects? Not necessarily, because again, when do you have the side effects? It may not necessarily be right at the time of injection, right? It could be something like 24 or 36 hours after the fact. So I would just say, treat as you become symptomatic. There's no point in taking the med. You're not necessarily going to get infusion reactions like you would from like infliximab or something, but it's usually 24, 36 hours afterwards when you're going to start to feel that sort of that inflammatory response, right? So that's what I would say to that. Are there people that might contradict me? Absolutely. That's totally okay too. Some people might say, yeah, take Tylenol beforehand. It's probably not going to hurt, Also, there's a National Vaccine Injury Compensation Program. So even if someone did have, a reaction to an adverse reaction to a vaccine, there could be something to do with compensation. So again, there are programs that are available there if need be. So again, always look this stuff up if need to. Now, again, this is going back to when swine flu was a big deal back in the day, and so this is really interesting. There's a warning I found. I don't know where I found it at. It was a couple years ago. I think I just Googled anti-vax or something, and this popped up. But just not to, I'm not trying to dunk on anyone and say oh, well, look how silly this is. But this is the kind of stuff that they're going to be seeing that could really put a lot of fear into people before they decide if they want to get that shot in their arm, right? So for instance, they'll see things like neomycins, an immunotoxin. Well, I mean, it's an antibiotic. I don't know if it's really an immunotoxin necessarily. Or for instance, potassium chloride, neurotoxin. I mean, yeah, but you're also dead if you don't have enough potassium chloride. So, some of this stuff, though, is kind of you see big names, people might not understand potassium chloride is potassium. They may think it's something different, For instance, you hear, all of our tap water is contaminated with dihydrogen monoxide. Everywhere's got it. Don't even drink the tap water. Dihydrogen monoxide everywhere. It's well, okay. So again, it's how they make these cases here. And again, if you have limited medical or chemical knowledge, and this stuff may seem really scary, right? So it makes sense why people might be a little bit hesitant, especially if they're hearing this from a lot of different sources in their own, little echo chamber they might happen to be in, which can be really tough. Someone said, I know this is mentioned early. Sorry, I missed it. What was the rate for fluid bolus? So fluid bolus, 20 mLs per kilo. You can give that over 30 minutes. In some ways, you can give it over 15 minutes, 5 minutes. I mean, it's a fluid bolus. You can give it as fast as you want if the emergency calls for it. Hopefully that helps. Anyway, and again, they say, okay, we just need Guillain-Barré and autism and stuff. And some of these things may have happened along with the vaccine, but again, it's very tough to tell, especially if these things are happening in very limited numbers, if there's a true cause and effect analysis here. But again, I'll show you a real life example that just happened today of seeing an adverse effect and saying, okay, well, what are we going to do about this? And so that's kind of to wet your whistle for the very end of the lecture here. So I actually added on. But in terms of specifically in the cases of vaccines and autism, there's a concern about a specific preservative called thimerosal, which does have some mercury is not the way you pronounce that, mercury. And so basically, CDC came out because again they hear a lot of this stuff and they say, okay, we want to try to allay those fears, and so they go back and look at the data. And actually, when you really kind of put everything together, there's no specific link between thimerosal and autism, or thimerosal containing vaccines and autism. Okay, did a lot of kids who have autism get those vaccines? Probably, but it's probably not any higher than in kids who didn't get those vaccines, right? So again, you have to kind of look at the cases of people who got vaccinated versus those that didn't, then look at the rates of the disease that occurred. So in this case, autism. And again, there's no specific links here that they can find. Okay. You may have some small studies that show there's something, but then you may have another study that completely discredits it. So a lot of times they rely on pooling data together. So that meta-analysis we kind of touched upon in EpiBio, where they can then look at a larger pool of people to see, okay, well, what is the real answer, right? And sometimes they can't come to anything definitive, but at least so far, we have not been able to show there's a clear link there, right? And again, it's good if you can have people who are, hesitant to get vaccines, point them towards good resources, right? Because again, if they're relying on Dr. Google to find their info, who knows where they might end up, right? So if you can link them to like credible websites like the CDC, that might be useful, right? Now, some people have inherent distrust of government, so maybe that doesn't help. But again, it just depends on the person. And again, having an open and frank conversation with them can be really helpful rather than coming down and saying, no, you must do this because I'm the healthcare provider, I am right. That doesn't really convince a whole lot of people, unfortunately. Okay, so looking at childhood vaccines, there's a whole lot that are here that these patients are going to be recommended, and this is why it is important that we go ahead and look for updates and things like that. The new schedule is always posted every single year in January on the CDC website, right? And so you may see some changes, but largely it stays roughly the same. I'm going to go ahead and open the link here, so I can show you guys what it looks like. I know you've already seen it, but just for completeness sake from my end, kind of showing you what you see here. And again, you can save this link, you can print it out. Just remember to go back in January to find what you need. And so basically, they will have the general, birth to 18 years schedule here. There'll be a separate adult one. You can either do it based off of the age of the patient. So this would be like what most normal or typical children would get. So they get like their hepatitis B, the first dose here at birth. They get the second one between 1 and 2 months. And then you can see here, they get the third one, that longer time frame, because again, that's an inactivated form. They give that longer time frame in order to make sure they get that really good immune response there, right? That really good durability, as opposed to if you gave it, say a month after their second dose, for instance. So this would be if they were on their typical schedule, coming and seeing the pediatrician at their recommended times, they should be able to get all of this, right? And you'll see things like, okay, if it's influenza, if their first time, they should get 2 doses, right? And we'll talk about that more specifically a little bit later on. Some of these may be more specific in certain cases, but again, it could be dependent on like the type of patient you're dealing with, things like that. And so there's a catch-up schedule as well that you can find. So that way they tell you the minimum time between doses, which is handy. So for instance, here you can see 4 weeks between dose 1 and 2 for Hep B, between 8 weeks and at least 16 weeks after the first dose, right? So again, giving that longer time frame for that. For instance, we'll also see some things start off at 12 months of age. So for instance, some of our, let me see here, like MMR, you're going to see that doesn't start off until 12 months. That has to do with maternal antibodies. So I'll talk about that in a little bit. But yeah, you just follow the schedule and you can keep yourself pretty much on track. In some cases, you may look at certain medical indications, right? So if they have certain types of disease states, like if they have HIV, this may influence what vaccines they need to get at what time. If they have heart disease, if they have, chronic liver disease. So again, I say, I don't know you need to memorize all of this, but you can look it up. Or if you deal with kids with congenital heart disease all the time, you're just going to know it, right? Because you're going to deal with those kids on a pretty frequent basis there. So that's what I would say from that. Again, you can look this stuff up. Know that it comes out in January every year. CDC is the main source to go for that. Someone was saying, on the interactions for the Pfizer vaccine, it said that if used Tylenol as prophylactic, it could diminish therapeutic effect of vaccine. What does that mean exactly? Would it be less efficacious? Yeah, so again, that's one of those things where I think it's more theory than it is actual what we know in terms of what the evidence has shown so far. Because again, this has been a very rapid turnaround for these vaccines here. But the thought may be that there's a theoretical concern by using Tylenol, maybe as an and again, I would see this more with like NSAIDs, I would think, because they're more kind of systemically anti-inflammatory, that would lead to a lesser response. But again, if you don't need the Tylenol, then don't take it, and then that way you can at least, even if there is a small effect, you can at least eliminate that if you can. I believe they said after 24 hours, though, you're certainly free to go ahead and use it, and that's when most people tend to get symptomatic anyway. So again, I don't know if there's like enough good evidence to say like, yes, specifically you must do that, but that's something they put out there. Probably more so to cover their own butts than anything else. In terms of the adult immunization schedule, some of these things you're going to find are recommended for certain age groups. So, for instance, like pneumococcal for 65 and older. And here you're going to find this gets a lot more specialized based off of specific needs. So, for instance, like things like travel, based off of certain disease states that they have. And so I'll show you some examples of that here. Getting pretty good at making sure I'm switching my stuff here. So this would be an example of the adult schedule, again from the CDC, published every year in January. And you can see here, depending on which influenza vaccine they want to get. Notice how some of these you can't give after a certain time frame due to concerns with reduction in their immune system. So the live attenuated one, for instance, you don't give after 50. And again, I'll go over some of these specifics a little bit later on. You can see here, giving Tdap can make a difference. If you're going to give this every 10 years or not. One dose of Tdap, but then afterwards you're giving TD, for instance. All these sorts of things here. The more important one I think is going to be important is the more important one I think is going to be important. Well, obviously, the thing I think that is more sort of influential is going to be their different disease states. So like what kind of disease states do they have? Are they pregnant? Which one should they avoid? That's good to know. Like for instance, like Tdap, like one each pregnancy, that one you're going to get repeatedly if you have multiple kids. If they are missing a spleen, you might get certain ones, or you might avoid certain ones. So again, if you have a specific disease state that might be affecting their immune system, just look it up, is what I would say to that. I'm not going to ask you anything specific off of here because, again, I would have to look it up too. So there you go. Someone said, are you supposed to rub the injection site to spread the COVID vaccine like you would the flu vax? Not that I've heard. I don't know if that's going to cause you any additional benefit from it. Not that I'm aware of, at least. Could there be something to it? I don't know. Maybe it makes your arm feel a little bit better. I don't know. Turns out there's a lot of things I don't know, as you'll see. So again, as I mentioned, specific groups of people will make a difference here. So pregnancy, HIV, asplenia, and healthcare providers as well, which I'll talk a little bit about in more detail here coming up. Also includes the contraindications, so which ones they should not be getting, which is just as important as which ones they should be getting in a lot of those cases too. So talking about the special populations, let's hit infants first. So as I mentioned, you start to get passive transfer of those maternal antibodies during the third trimester, and then you can see that those antibodies will inhibit the response to live vaccines. So that is why things like MMR you don't give until 12 months due to this, okay? By then, they have gotten to a point where their digestive system is mature enough to where they're not going to be really absorbing a ton of those antibodies from the breast milk anymore. They will be able to mount their own good immune response to that stuff. So that's why we delay some of those until 1 year, basically. If you do have a premature infant, they get vaccinated based off their postnatal age. So you don't do it based off of gestational age at all. And again, they're even more susceptible to disease because they are born so immature. So they get the same time frame there. Again, by the time they're a month or 12 months old, again, they should be able to get a good response to their live attenuated. In pregnant women, generally speaking, benefits outweigh the risk for the most part. But again, you may have some patients that are, again, even more vaccine hesitant because they are pregnant, because they worry about unintended effects of their fetus, which is, again, it's a valid concern to have. If you have anything that happens to your kid, you always think, okay, I was the one that did that. That's not a good feeling. Typically speaking, though, that we don't find any adverse outcomes really ascribed specifically to vaccine administration in this patient population. But some things we do recommend pretty routinely, again, avoid live vaccines because of a theoretical risk it could cause issues for the fetus. But generally speaking, if it's an inactivated form, you're good to go. The primary ones you're probably going to run into most frequently, though, are going to be your influenza. So if it comes to be flu season, pregnant women should get the flu vaccine, right? Let's have some other contraindication. And then for the Tdap, they do this specifically for the pertussis risk, right? Because Tdap stands for tetanus, diphtheria, and acellular pertussis. We do this to prevent things like whooping cough in that infant once it's born, right? And generally a lot of close contacts like the dad or any other partner, family members who are going to be close contact, they are generally recommended to get it as well. Not with every pregnancy. So for instance, I think my wife got Tdap for both of our kids. I only got it the first time because it's not recommended for that close contact. After that, I had my booster totally fine after that, Some said maternal antibodies are present. Why can we give vaccines like Hep B before 12 months? So it's just the live attenuated vaccines that are going to be a problem. Maternal antibodies will neutralize the live attenuated form. If they're inactivated, then it's okay to go. The maternal antibodies don't provide that big of a barrier to their efficacy. But again, that's also why a lot of those inactivated forms, they get multiple doses. So even if the maternal antibodies affected the first dose, by the time you get the second, third, fourth dose, you're generally good to go. So from that standpoint, that's why it's not going to be a big problem for them. Okay. Any other live vaccines though for pregnant women? You can just defer until after birth, and then that's fine for them. So for immunocompromised conditions here, so we have things like congenital immunodeficiencies, leukemias. If they're on chemotherapy, again going back to your steroids here, prednisone doses greater than 20 milligrams per day, or for greater than 2 weeks, right? So there you go. So that's kind of what we're talking about there. Being on a high enough dose could potentially lead to some issues here, because again, that does put you into immunocompromised state. If they're topical steroids, if it's an intra-articular steroid, if it's an MDI like a fluticasone inhaler, or less than 2 weeks, they're not considered immunosuppressive, so we wouldn't treat it like that. However, if they are in greater doses than that, more than 14 days, that's when you consider them to be sort of in the immunocompromised state there. Generally speaking, though, if they are severely immunocompromised, they should avoid all live vaccines because of the fact that they can actually get the disease in question. Other vaccines, as I mentioned, may not elicit a full response, but they may give you some response, which is better than nothing, especially if they're immunocompromised. So again, that's why I would still say go ahead and vaccinate them, even though they may not get the full response there. So for healthcare providers, they recommend annual flu vaccine. Now, we'll talk about flu specifically, and there's going to be a trivalent and a quadrivalent form. We'll talk about what that means here in just a little bit. But any of these are totally fine for the flu vaccine. We'll see the hepatitis B, as I mentioned there. If they've never been vaccinated before, then they would recommend a series done, and then they can do serological testing, and if they need to give another dose, they can do so, basically. So you wait 1 to 2 months afterwards. Since I had a history, myself personally had a history of being vaccinated for Hep B, I just needed that titer done, and they found they needed to give me a booster, for instance. So some of you might be in that same boat, potentially, or might be young enough to where you don't have to worry about that, right? For Tdap, we're going to see here that basically TD, which is just the tetanus and diphtheria, they do recommend that every 10 years after they've gotten the initial series, or in some cases you will find if they have like close contact with the patients, they'll do the first time you do a booster will be Tdap. So you kind of get that additional boost from the acellular pertussis, especially if you're going to be dealing with direct patient contact, because they may be passing stuff off to you, and that keeps you from giving out to someone else, for instance. So typically you'll see Tdap for the first dose, and then TD for every dose after that. A lot of times, especially in patients that they're not sure when they've gotten their last dose, because again, it's hard to remember stuff that happened even last week as opposed to 10 years ago. Oftentimes we just err on the side of giving them the booster. You'll see that pretty frequently. With varicella, if there's no proof of immunity, they may recommend giving a vaccine schedule for that. So, if you had a history of chickenpox or something, then you're probably not going to have any issues with that, but they can check for immunity. And then, interestingly, with MMR, if you're born in 1957 or later without serologic evidence of immunity, then they would give you a vaccine series for that. Okay. Again, if you can provide documentation, then generally they're not too worried about it at that point there for a lot of these. Meningococcal, this one's very specific. This is going to be for microbiologists who are working with Neisseria specifically because, again, they're at such risk because they're directly in contact with the stuff. So those are kind of special populations you might be dealing with on a day-to-day basis there. So anyway, let's go into some of the vaccines in depth here. Not in death. That would not be good. That would make people very vaccine phobic if it led to death. Anyway. So HPV is kind of an interesting small DNA virus, and there's a lot of different subtypes that are out there. The real reason why we care about this is because it is highly spreadable via sexual contact, leading to things like genital warts. Certainly see other types that cause warts on the hands and feet. But the ones we care a lot about tend to be certain types that can cause things like cervical cancer, for instance. And so things like high-risk types happen to be like 16, 18, 31, 45. Some other ones might be more low risk, but they're more likely to cause like the genital warts. They might not carry the same sort of cancer risk. The reason why I mention the types here is because we're going to see that you can have different vaccine types and maybe focusing on different numbers of types, right? You may see they have different numbers of valences that may be trying to attack different types of the virus, which I'll show you in just a moment here. Someone's asking, do you need a booster varicella vaccine to prevent shingles? I don't know that that is possible, but honestly, I'd have to look it up. I haven't looked at that specifically in a little while, so I'm not sure about that. They just mean you need to be on like suppressive therapy potentially for that. So I am not 100%. I need to look that up. If you find an answer, you can always post it up in the chat, and I'll take that. So anyway, a lot of new cases every year that get diagnosed with HPV, and and again, just looking at greater than 80% of sexually active women have acquired it by age of 50 years, right? So it's huge. It's everywhere. A lot of people may be asymptomatic. Also very common in men, but the real reason why we care with this is because it's been associated with a large percentage of cervical cancers. There's the varicella shot. I don't remember the specifics with shingles specifically, so I'd have to look that up there. Anyway, with again, you can see here 70% of those cancers are associated with 16 and 18. It also causes like some anal cancers there, and then you can see that a lot of the genital warts are caused by 6 and 11. So you can see there's certain high priority targets you'd want to shoot for, because these are the most common ones that cause either the cancer risk or risk for things like the warts there. Let me get back to that question in just a moment here on the sticky bar. I'll talk about that in just a little bit. I don't want to get too off topic here. So as I mentioned, a lot of people who have HPV are asymptomatic. I may not realize that they have any clinical disease there. Yeah, shingles vaccine you definitely get if you get a splenectomy or something like that. But again, I have to go. And again, I always look this stuff up if I need to, and I don't really deal with a lot of patients like that, unfortunately. But yeah. Anyway, so with this, you can see, as I mentioned, a lot of cervical cancers, anal cancers associated with that, and so this is why it was kind of a big target to see if we could try to prevent some of those cancers with a vaccine, basically. So initially we had Gardasil that was approved in June of 2006, right? And so basically this was approved for females between ages of 9 to 26 years of age. So kind of limited in terms of who was going to be able to get it here. And it was considered to be quadrivalent. Quadrivalent means it's going to be shooting for 4 different types of the virus. So it's going to be getting the 2 big ones for cervical cancer, and the other 2 that are most likely to cause the genital warts. So kind of getting the best of both worlds there. Again, it may not prevent all cases, but it can prevent a lot of them. Not only that, but it can also prevent spread to other people, which is pretty handy. And this one here you can see was a 2 to 3 dose series they'd be getting there. If you notice, the time frame looks pretty similar to what we saw before. So 4 weeks between doses 1 and 2, and then 12 weeks between doses 2 and 3. So you give that additional time frame to kind of give the body ability to get a more durable response out of that. Yeah, Zostavax is the shingles vaccine. But again, I'm trying to think of people who already have shingles, all that. I'd have to look it up. I'm sorry. I don't know everything. I apologize. Now, there was certain types, if you just wanted to focus on just the risk for cancer, there was Cervarix, which was just for 16 and 18. I don't think this really ever got off the ground, so to speak, because, again, if you could prevent things like genital warts, why not go ahead and do that as well? I think when this first came out, there was a lot of concern. And again, to put this in perspective of time, this is June 2006. I was like in undergrad still. I think I just started pharmacy school, perhaps. Not to age myself, but and I remember hearing concerns about this as being like, well, if you give young women this is going to cause them to be sexually promiscuous, because now they don't have to worry about getting STDs. And it's like, well, I mean, not really, because they can still get a lot of STDs, so I think those kind of unfounded fears, but that was a concern. But since then, we also have the nonavalent, Nona being 9, which protects against a wider variety. So this is probably the more common one you're going to see out there. So the Gardasil 9. Again, I don't care that you remember the specific numbers here, but if I'd say something between like a quadrivalent versus nonavalent, you should know what that means, basically. So basically, they would recommend routine vaccination of adolescents, right? So initially it was just females. Then they expanded it out to be like, well, wait a second, guys can get this too. So they said all adolescents 11 to 12 years of age can be started as young as 9 years at the clinician's discretion. So they feel like it would be recommended, then they can do that potentially. And then if they've never been previously vaccinated between ages of 13 and 26, we recommend for females there. For male patients, they'd recommend it between 13 to 21. They would say if you are 22 to 26, then there could be some compelling indications to do it at that point. So if they're immunocompromised, so for instance, if HIV, men who have sex with men is one of those other categories where they saw a high degree of spread there, so they also recommended it there as well. And if possible, try to start the vaccine before onset of sexual activity. Now, that may be tough because, if the patient's having to come in with their parent to get their shots, they may not be super open about that. But, in some cases, you may be able to kind of, talk to the patients by themselves and maybe get them to open up a little bit more. But ideally, start it beforehand, so that way they don't have it already. Yeah, so since then they probably expanded a little bit. Right, so I may need to update that, but yeah. So again, having that expanded indications, but again, who's it like? If you're looking like priority indications, like you'd probably want to do this before they have the HPV in the first place. So that's why they kind of focus more so on the younger ages there. But yeah, certainly you can probably get even up higher than that. But so that was kind of the initial recommendations there, a little bit more up to date. So but thank you for that. I can certainly add that in, or double check on that. As I mentioned, if they already have existing disease, then especially if it's a type that it protects against, and it obviously is not going to do anything for that. But if they, maybe they already have type 6, for instance, but they don't have any of these other types, then that would provide protection against those. So there still are going to be some benefit there. And again, vaccination is okay for those 26 age or younger who have any of these things here. So the breastfeeding, immunocompromised, lactating, any of these things here, they're still fine to go ahead and get the vaccine at that point. Yeah, I think some of the concern there, at least initially, was delay or not having it any older than that. It was just because the likelihood of them being infected was probably pretty high. But that's just how they were kind of scaling the recommendations. So as you see, as time's gone on, they sort of expanded that out further and further. So it's one of those things that may develop. Just like with the COVID vaccine, we started with adults, and now we're starting to back it up, go backwards in terms of now 12 to 18 they're starting to look at as being potentially available there. So sometimes age ranges can change depending on the disease state in question. Let's see, someone said, if you take steroids for enhancement purposes, would that cause you to become immunosuppressed with long-term steroid use, therefore increasing your chance of having a bad side effects from COVID? So we say steroids for enhancement purposes. Are we talking about like androgens or corticosteroids? Because really it would only be corticosteroids that would be causing the problem here. I don't know of any interactions between like androgens or estrogens or anything like that would cause a problem, because they don't directly affect the immune system, or at least nearly as strongly as you would see with something like a corticosteroid. So not that I'm aware of, but again, there's a lot of stuff we don't know yet, because again, we're still vaccinating a lot of people, and some of the stuff we may not know for years potentially, right? Anyway, with the cervical cancer screenings, the recommendation doesn't really change whether they're vaccinated or not. They should still get their normal screenings. So it's important to educate them, let them know this is still something they should be getting on a routine basis. Okay, next we have the flu vaccine. And so again, we know influenza, large particle droplets, airborne transmission, and we can see that patients may be asymptomatic and still be spreading the disease to others, since it has that incubation period. They can still be shedding virus there. And then with the virus shedding itself, even 5 days after onset, they can still be shedding. Kids even longer than that, and certainly immunocompromised people who cannot clear it on their own could be weeks to months potentially, right? And again, when do you normally see peak flu activity? Well, typically around the winter months, right? Again, because people are inside, they're all breathing on each other. The virus tends to like the colder weather, so that's when you typically see the spikes in terms of incidence of disease, right? And so basically, influenza vaccine gets recommended for all kids 6 months and older who do not have a contraindication. So anyone 6 months and older is going to be able to get the flu vaccine, and we formulate it every single year differently. And so there's what you're going to find is there's both a trivalent and then a quadrivalent form. The original ones were all trivalent, meaning they only were going target against 2 influenza A strains and 1 influenza B strain. So, and they would sort of predict, like you'd have all these epidemiologists trying to say, well, what do we think are the most common strains of influenza that are going to be present this year? Sometimes they guess really well, sometimes they guess pretty poorly. So that's why you can see pretty variable rates in terms of flu from year to year based on how well they pick the strains. If you guys don't recall, when the swine flu was a big deal, that was a type of influenza B, or H1N1, that's when we started to see more quadrivalent forms. And so now we get 2 A's and 2 B's typically. So that's kind of the big difference there between tri and quadrivalent, similar to what we saw with the quadrivalent versus a nonavalent, for instance. So most of them you're going to find are going to be things like Fluzone, Fluvirin, things like that. They're going to be the inactivated vaccine, and this is the one you get intramuscularly. This is going to be good for anyone greater than 6 months of age, right? So even if they're particularly old, they can still get this one because we're not really worried about their immune system and them getting the actual infection itself. Typically, kids that are less than 9 who are getting vaccinated for the first time, you want to give 2 doses for. So you want to do it 4 weeks in between doses, and you can give it at the same time as other ones because this is inactivated, so that's not a problem. There is a recombinant form, and this is going to be for patients who have a history of egg allergy. So if they could not receive the inactivated form because of the egg proteins there is a recombinant form. So that's something just to note with that. There's the flu mist, which is the intranasal form. And again, this is another quadrivalent, similar to how the Fluzone is. But this one is going to be, again, given intranasally. This one's only for people aged 2 to 49. Because this is a live attenuated, you worry about in those extremes of age in terms of their ability to be able to not develop the actual flu itself. Because for those people, they actually could get the flu potentially. This is another case where 2 to 8, you still want to get 2 doses of the live attenuated form. Again, probably 6 to 10 weeks between doses. So you can give it longer there to make sure they get good immune response there. Because this is a live one, if you're giving other live vaccines and you want to separate them out by 4 weeks, that rule still applies there. So someone's saying, for Tdap, you mentioned every 10 years, but I thought the patients had a wound infection, animal bite. You would ask if they receive a tetanus shot within 5 years. I may be wrong. I'll talk about tetanus here in just a little bit. So I'm going to bring that up in just a second here. I'm glad you guys have all these questions. I appreciate that. With the flu mist, the contraindications again include things like the egg proteins there. They also worry about things like concomitant aspirin use in kids or adolescents. Part of this is because there's a little bit of aspirin that is part of the formulation for the live attenuated form. So that is going to be another contraindication, especially like Ray's syndrome risk, things like that. And then not recommended. Immunocompromised, pregnant women, they have egg allergy. They also mentioned kids 2 to 4 years of age with asthma or wheezing episodes that didn't have a worse time with this. You could see an interaction there. And then if they've had any antivirals within 48 hours, because that could interfere with the ability to mount a response against that. So if they've been on like Tamiflu recently, within 48 hours, you'd want to go ahead and separate that out by that time frame. Okay. Someone's asking why would someone get intranasal versus IM flu vaccines aside from fear of needles? That's probably a big one. Maybe convenience, maybe, I don't know. I've never gotten the intranasal. I've always gotten the intramuscular. But that could be probably a big reason why is just the needle phobia, especially if you have to get it every single year. So that would be my thought. Clinically, they work just as well because they're going to be covering the same strains of flu, right? Next up is an interesting one. Rabies is a neurotropic RNA virus, and this has a really high fatality rate, probably the highest of any infectious disease out there. Fortunately, there's very few cases, and interestingly enough, you can find rabid animals potentially anywhere in the U.S. except for Hawaii. They don't really have any rabid animals over there, I guess, unless you took, I don't know, like a mongoose or something over there. But so this is something that is clinically not likely to be all that. You're not going to run into too many cases of rabies. And if they're already symptomatic, chances are they're probably not going to be alive for too long. There's some pretty wild case reports out there of people who have survived it, but it usually included being put into a medically induced coma and really going through some heroic efforts to keep these people alive. So pretty wild stuff. Typically, you're going to see this is most likely done through bites, animal bites. Rarely can you see things like transplantation of like organ tissue. Normally, you're going to be testing for this beforehand. There's actually an episode of Scrubs of all things where they actually had a case where someone had a transplant and gave a bunch of people rabies, I think, which is pretty, I thought kind of odd at the time, but I guess it has occurred in the past. And then in a lot of developing countries, like dogs typically are going to be a lot of the carriers for rabies. Here in the U.S., you're more likely to see things like bats, raccoons, skunks, and foxes being most likely to carry this. So certainly bats here in Florida, see plenty of those, raccoons for sure, all your trash pandas. I'll give you the whole list of animals, don't you worry. Those groundhogs, of course, are always causing winter to be longer. How dare they? Anyway, so this is really interesting because the virus itself will normally be inserted into a peripheral wound. So say like get bit on the hand or something, it will then travel through the dorsal root ganglion. So it's traveling up these nerves all the way up into the brain. And so the idea is that you want to try to prevent that spread as best you can. There's certain ways we can do that. And then once from there, they can start to secrete it like the salivary gland, so they could bite someone else and then spread it to them potentially. And so things that affect the risk include things like the infecting variant. So what the animal is doing it, how big of an inoculum do they have, the actual site innervation. So more innervation means more likely to spread. And then does the host have immunity? Obviously, if you work in a high risk profession, like if you're an animal catcher or something like that, you might be more likely to get pre-exposure prophylaxis and get immunized beforehand. But most individuals are not immunized against rabies because we don't run into that many rabid animals here in a lot, or at least in the U.S. for the most part. Now, certain parts of Florida, that's certainly not the case. You may find a lot of rabid animals. The clinical manifestations are also really just as interesting. They can have things like aerophobia and hydrophobia. So they you can like blow air in their face and they get very kind of spazzed out about it. You'll see these kind of paralytic symptoms as well. So this quadriparesis, and that's ultimately what probably ends up killing these patients here. So ideally you want to get to them as quickly as possible, because once they start to become symptomatic, there's very little you can do for those patients once it gets into the CNS, unfortunately. And again, some cases it could be 1 to 3 month incubation time, could be up to a year in some cases. Just depends on where it's spreading from and how long it takes to. So lower extremities would incubate slower than something like an upper extremity, something closer to the brain, for instance. So what do we do here? Obviously, with wound care, cleaning with soap and water is going to be really important. Professional raccoon wrangler. Well, that was a past profession of mine. I don't know how you knew about that, but anyway, so if you can use something that has virucidal properties, so something like iodine-based product, that really reduces your likelihood very significantly. And then we'll talk about antibiotics and tetanus prophylaxis. So we do have an immune globulin that's available to us. Basically, you use a dose of 20 international units per kilogram. We have different varieties here, like hyperrab or imigam rabies. There's also an equine derived, but that typically does cause more immunogenicity. You're more likely to see allergic reactions as a result of that. The benefit of this is it causes immediate neutralization of the virus. Okay. Basically, what we're going to do is you will try to infiltrate as much as you can around the bite site, and then if you have any left over, you can inject that intramuscularly to provide some systemic coverage. But again, where is the virus at? Well, it's probably close to the bite, especially if you got to it within a few hours. You can basically infiltrate and around the area, and that will neutralize any virus that's there. So that's the immune globulin we're giving for initial neutralization. Afterwards, you're going to then give the vaccine to follow up with that, and that provides additional benefit over the course of many years, obviously. So we have things like, Imivax, which is human varieties, one that are derived from chicken embryo cells. So there's different kinds that are out there, Rabivert, Imivax, just as some examples. And again, we'll be dosing differently based if it's pre-exposure prophylaxis, like if you're in a high-risk profession, if you're a professional raccoon wrangler, as you mentioned, or if it's post-exposure, right? Here we're going to find we don't want to administer this in the gluteal area. The deltoid is going to be preferred. You get better responses out of that when using the vaccine. Just to give you some ideas of how we'll be dosing this for post-exposure, which is where you're most likely to run into it, because you might be working in the ER, the urgent care or something. You'll do it at day 0. So this is another case where you're giving the immune globulin and the vaccine at the same time. Doing this at day 0, 7, 21, 28. If you had received vaccination beforehand, so say you're that raccoon wrangler and you get bit, then you could go ahead and give yourself a booster, not yourself a booster, but get a booster at day 0 only, and then they're generally fine at that point. Let's see. So someone said, do you only give the immune globulin if there's a definite bite from a rabid animal, or is it also sort of prophylactic like the vaccine? I have a flow chart that will show you all that just here in a moment. So here we go. So a lot of times, and I think a lot of people are quick to pull the trigger and say like, yeah, let's go ahead and give the immune globulin. Let's go ahead and give the vaccine. And remember, if you're in the ER setting, you're not going to be following up with them for all those extra doses. This is the benefit of coordinating with your health department. And this is one of those reportable diseases, and they will then follow up with the patient, make sure they get the full series. So you'll give them day 0, call the health department, and they'll be able to set up follow-up with the patient so that way they can get the full series. So question are, okay, did the patient have exposure to rabies potentially occur? So you got to go through all these questions and make sure that you actually need the stuff in the first place. So looking at this, did a animal with fur bite the patient? Okay. Was it a salamander? Okay, probably not going to need rabies prophylaxis, right? Did the patient's open wound, broken skin or mucous membrane, contact saliva or central nervous system tissue from the animal? Okay. 3, 7, and 14. I'm not sure. At least the one I was saying, is that for pre-exposure prophylaxis? I'm not going to quiz you on the days though, so don't worry about the day portion there. So if you need to know for that, then but as far as I know, I'd have to look it up. But I'm kind of crunched for time, so let me see what I can get through here. Yeah, time frame is different if it's pre or post exposure, so I have to look that up. But let's say they and this is the case here where the interesting thing with bats is normally you're going to know if the patient was bit by a dog or something like that. If it was a bat, even if you wake up in the middle of the night and you found there's a bat in your room for something, which is terrifying, then you can't rule out a bite necessarily because their fangs are so small, you may not be able to see the bite. And so in those cases there, you may need to consider go ahead and dosing. Alyssa's saying, how do you know where to inject the wound if you don't have a wound or bite site? We're only in the room with the bat and seeking post-exposure prophylaxis. Then that would need to be IM. You do the IM dosing at that point. So, if the days are mixed up, then again, I'm not going to ask about that specifically on the test, but you can certainly square that away for ID for sure. So anyway, so then you're going to say, okay, was it a high-risk animal here? So was it a bat, raccoon, skunk, fox, coyote, bobcat, or woodchuck? I don't know where you run into woodchucks at, but around here, certainly we have plenty of raccoons, we have skunks, things like that. So at that point, okay, are they available to test? That's another big question. Do you have the animal available? If not, then you go ahead and start the post-exposure prophylaxis promptly. If you do have it, then you're able to test the animal to see if they actually have it, which is usually a fatal test, but you can test the animal, and then if you need to, sometimes they'll go ahead and put the animal into quarantine, especially if it's like a household animal or something. But for these animals that are wild, they'll probably end up killing it to be able to do a CNS test to see if they're positive or not. Now, if it's something like a squirrel, a mouse, a rabbit, don't worry about it. It's very low risk, not likely to run into any problems here. Dog, cat, or ferret. Again, if it's unavailable, which hopefully if it's like a household animal, you'd at least have some ability to get access to it. And then if they have known rabies immunization, they can provide records, then you don't have to worry about it. If they can quarantine animal for 10 days and they don't show any symptoms, then you're okay to go. You don't have to worry about it. Unfortunately, though, if they're unavailable, then you have to err on the side of caution, especially depending on how severe the bite is, things like that. You may go ahead and start the PEP at that point. And then questions like, okay, is it pocket pet? I guess like a Pokemon, if you so to speak. If you have a Bulbasaur around, perhaps that might. Probably not that. Maybe a Pikachu might carry rabies, if I had to guess. But is it kept indoors? Yeah, you probably don't need to worry about that. Or if it is kept indoors, you probably don't need any PEP. Otherwise, you may need to look into contacting your public health authority. So that's basically the Florida Health Department. You can call them up and see what they think there, because they're really going to be the experts there. ID lecture rabies immunoglobulins administered. Immunoglobulins. It should be the immune vaccine, but let's look it up real quick. Why not just settle the point now? Because now you got me curious. I don't want to say I put something wrong on there. Oh, did I get it wrong? Maybe I did. Let me look at my slides here. Oh my goodness. Let's see. You know what, you guys are right. So here's a lexicon here. I'll show you. There you go. So okay, I want you guys to think of which Pokemon are most likely to carry rabies. I know a lot of people think which ones are most edible, but there you go. Yeah. So for pre-exposure prophylaxis for the vaccine, it's going to be 0, 7, 21, 28. So that'd be an animal handler. So that's a mistake on my slide. I apologize. Post-exposure, if they're immunocompetent, then 0, 3, 7, and 14. So I'll update that. Again, that's not going to be a question in my test. Just FYI. Okay, so someone's saying, do you only give the immune globulin if there's a definite bite from the animal? No, so again, like we said, if it was a high risk, Zubat, thank you very much. So if it was a high risk animal, then yeah, you go ahead and do the prophylaxis there. You do the immune globulin and the vaccine for those cases there. If a high risk animal tests negative for rabies, does that mean the person with potential exposure does not need? Yes, that is correct. If the animal tests negative, or if they can quarantine the animal for 10 days and it's negative, then you don't have to worry about doing the prophylaxis there. So. All right, so your ID slides are correct. Mine were incorrect. That was for pre-exposure, is what I had on mine. But again, not too concerning there. And again, if you run into it, because you might only run into it like once or twice a year, you can always look it up, right? Okay, let's see. Anyway, so that's kind of the general thing. So again, how high risk was it? Depends on the animal. I think like mongoose are particularly high risk as well, but we just don't have a lot of those that are indigenous here to the U.S. I would definitely say that as well, Kelly. Definitely sus there. Okay, so tetanus, real brief. I'm just going to see what I can get through. So next with tetanus, again, this is where we see Clostridium tetani. We worry about the exotoxin here is what really the big concern is. And so this is something that's not contagious, but is still vaccine preventable. So it's kind of a unique thing with that because you can see it in the environment, right? So if you have like a wound, if you step on a nail, if you're on a motorcycle accident and you kind of you become a meat crayon, as some people might say, you're skidding along the ground there. The big thing we worry about here is the fact that the tetanus toxin blocks the release of glycine and GABA. So again, those typically are inhibitory neurotransmitters. When you're blocking that, it's what leads to these really severe muscle contractions there. So you see muscle spasms that can lead to things like pneumonia, PE, or aspiration pneumonia. So lots of issues with this. And so this is why it's a concern, why we like to pre-medicate if we can for that. Someone's asking a question here that said, what would pre-exposure mean? Like, you're going to be around rabid animals. Yeah, so if you're going to be, so I think animal catchers, right? So if you're going to be working as an animal catcher, if you're around potentially rabid animals all the time, then you'd want pre-exposure prophylaxis, right? Just like the microbiologist getting the meningococcal vaccine. If they're going to be working with isolates of Neisseria meningitis, then yeah, you want them to go ahead and be vaccinated. So that's why we would do that. Let's see here. So what we can do is actually give the tetanus toxoid. So this is going to be given to sort of get your body to be able to develop antibodies against that, and it does provide protection for about that 10-year period there. As I mentioned, when we're doing wound care management, you're typically given as TD. So it's the tetanus toxoid plus diphtheria. And again, you may find it as well with Tdap or DTaP. DTaP is going to be the for kids less than 7. Tdap is for everyone over 7, basically. And so we can also give the tetanus immune globulin, but we only do this if we see like really severe wounds and we have unvaccinated individuals. And I have another flow chart here to show you what we would do. So in this case here, if we would look at their vaccination history on the y-axis here, and then the kind of the wound of how clean or minor it was versus if it was kind of everything else, right? So if it was a large wound, dirty wound, things like that. So if they have unknown or fewer than 3 doses, then yeah, you're going to go ahead and give them the TD. Totally fine there. If they are up to date, right? So you can see a single dose of Tdap, use the next dose of greater than 10 years. Let's see, where does the C at? Yeah, so you can consider if it's more than 5 years since the last dose, then yeah, you can go ahead and do it depending on the wound here. So if it was a more severe wound, then yeah, you could do it. Again, will people probably err on the side of caution in giving it before and just doing it within 5 years? Yeah, probably. Is it going to be a problem? Probably not, right? So again, having a little bit extra or having it too soon, better than having it not at all in those cases there. So, but if it's a clean or minor wound, then yeah, you probably don't need to necessarily give it if it's been more than 5 years. If it's been more than 10, then yeah, you go ahead and definitely give it at that point there. So otherwise, for these minor wounds, you don't need to worry about the immune globulin. If their vaccination status is, again, unknown or fewer than 3 doses, then yeah, you go ahead and do the full court press for any of these larger, dirtier wounds. If they've had previous vaccination, then yeah, you probably don't need to, unless they need a booster shot of the TD or Tdap, but the tetanus immune globulin typically not needed. So really the only case you need the tetanus immune globulin is that they have a dirty wound, large wound, they've never been vaccinated, or you don't know if they've been vaccinated. That would be the case there, right? Because again, you have someone who's a trauma patient who is unconscious. They may not be able to tell you when they got their last vaccine, right? Anyway, so I only have a couple questions left. So going back to someone's question over here for Tdap, you mentioned every 10 years. Yeah, so excuse me, depending on, again, how bad the wound is, how dirty it is, then yeah, you can do it within the 5 years there. Okay, so that you were not wrong. That is correct. And the CDC guidelines will sort of back you up on that as well. Got a lot of slides left. I'm surprised how long it actually took me to get through this. So let me go and cut it off there. We're almost at time. We'll finish this up tomorrow and then start on our toxicology stuff. So tomorrow we'll have plenty of time to talk about, because I don't want to get into like the COVID stuff and then not be able to finish it up. So we will kind of reconvene tomorrow about that, which I think we meet at 2:30 or 12:30 more. Yeah, so we'll meet a little bit earlier there tomorrow. So get your questions ready. We'll talk about the J&J stuff, which is pretty interesting. I was hoping to cover it today since it just happened today, but I guess if it's 1 day old, it won't be too big of a problem. But yeah, you probably won't be able to get J&J for at least for right now, since that's been paused due to some issues of blood clots. that occurred in a small number of individuals, but it's interesting developments there. Anyway, do you have any questions before I let you go? We've already had so many. I love it. But I'm always happy to have more. I'm going to save these two for tomorrow if you don't mind. Actually, wait, I think I haven't talked about this one, but unless you want to clarify that one. Otherwise, yeah, I will. Yeah, we'll talk about that one tomorrow when we get into the COVID stuff. Any other questions? If not, you guys are free to go. I know I gotta give you something to keep you coming back, right? I gotta leave you with I gotta leave a cliffhanger here for you. So Shelby's saying there's only 3 cases of rabies per year in the U.S. Numbers regarding those that weren't treated soon enough and actually got rabies, I would assume it'd be more than 3 per year. So that would be the actual like laboratory confirmed cases of rabies. It's exceedingly rare how many times that occurs because we do have either a lot of the bites are low risk or they get treated basically. Yeah, so pretty uncommon to see that. Yeah, I'm glad you thought it was interesting. I hope every day is interesting, but you know, not everyone's as big of a fan of urology as they are vaccines, I guess, and that's no fault of the topic. So anyway, yeah, you guys have a great day, and I will see you all tomorrow.